Hi, everyone. My name is Dr. Hala Borno. I'm an assistant professor of medicine at the University of California, San Francisco. I practice clinically, treating primarily advanced prostate cancer at the Helen Diller Family Comprehensive Cancer Center as a medical oncologist. I'm also the CEO and co-founder of Trial Library, a public benefit company in clinical trial access. Today, I'm delighted to be invited to speak with you on equity in clinical trials, and we're going to be focusing on prostate cancer. These are my disclosures. So first, we're going to talk about the epidemiology of prostate cancer. We'll review the background on inequity in clinical trials. We'll go into definitions, including understanding recruitment science, as well as gatekeepers, outlining barriers in clinical trial recruitment, and then closing with evidence-based strategies to promote equity. So first, let's think about prostate cancer on a population level. We recognize this is a very large burden of disease in the United States, and that 1 out of 8 men will be diagnosed with prostate cancer during their lifetime. But this disease does not impact us all equally. We know that in the United States, Black men have the highest incidence in cancer-specific mortality associated with prostate cancer. In fact, 112 per 100,000 men across all races are impacted by prostate cancer, but we see the highest incidence here among Black men at 183 per 100,000. When we look at mortality across all races, about 19 per 100,000 men are dying of this disease, and we see that 38 per 100,000 men of Black racial ethnic background are dying from this disease. So clearly, prostate cancer has inequities in whom is impacted and dying from this condition. Given that, how are we doing in terms of clinical trials? We know that there are a variety of canonical clinical trials that inform our standard of care. And I want to first think about it in the localized disease setting. The localized disease setting, the PROTECT trial provided level 1 evidence that there was no difference in prostate cancer-specific mortality among patients who received radical prostatectomy, radiotherapy, and active surveillance at 10-year follow-up for low risks, Gleason 6, or intermediate risk, Gleason 7 prostate cancer. But yet, when you look at the composition of participants in the PROTECT trial, you can see that actually less than 1% of this international trial were of African or Caribbean descent. How can we make valid conclusions about active surveillance in the context of these demographics among study participants? Now, shifting to the advanced disease context, Dan Spratt and colleagues summarized the enrollment of Black men in castrate-resistant prostate cancer. And they looked at 7 landmark phase 3 randomized controlled trials that led to the FDA approval of 5 new therapeutic options in the CRPC setting. And when they looked at these data, they found that among 7,250 men that enrolled in these clinical trials, only about 3.3% of them were Black men. This clearly demonstrates consistent inequities in whom prostate cancer clinical trials are serving in the localized early disease setting as well as the advanced disease setting. When we look across all tumor types, clinical trials lack representation. Here you see 2 bar graphs. On the left side, you have the percentage of US population that are by race ethnicity, baby blue being non-Hispanic white, African American being in dark blue, and then orange being Hispanic or Latinx origin. When you look at the bar graph on the right, you see the percent of participants in cancer clinical trials. And if we were achieving representation in clinical trials, these would be mirroring each other. The composition and the breakdown of patients in the United States would match the composition and the breakdown we see in our clinical trials. But what you can quickly tell here is that, in fact, these do not mirror each other, and the vast majority of participants in cancer clinical trials today are non-Hispanic white. And that's what we saw when we looked at the prostate cancer clinical trials, that we were not achieving representation, and in fact, we're achieving pretty significant underrepresentation. Why is this important? Well, it's important for a variety of reasons. One is the future. If we ensure maximal inclusion in clinical trials, then we know we're developing therapeutics that can be safe and effective across populations. 2, we also know that clinical trials have outcomes that are beneficial for patients. Here you see outcomes in pooled clinical trials. There was an increased overall survival in Black patients versus white patients enrolled in pooled trials. This plot here is overall survival. This is time. And Black men had a statistically significant decreased risk of death compared to white men when they were enrolled in metastatic CRPC clinical trials. So this is sort of an equal treatment setting situation, which is a clinical trial. We see that patients do well on clinical trials, and we lose the health inequities that we see on a population level in the clinical trial setting. This is part of the why this is important, that we need to address inequities in whom clinical trials are serving today. So let's think about the science around clinical trial access and clinical trial inequities. It's been long recognized that we have a lot of work to do in clinical trial access. And in 1993, the NIH issued a mandate. It's called the Revitalization Act. It mandated the inclusion of racial ethnic minorities and women in publicly funded clinical trials. But this mandate did not have a process around accountability to make sure that we're actually doing this work. What it did do is it spurred a field of inquiry, and this field is called recruitment science. Recruitment science is an empirical body of studies scientifically evaluating the efficacy of various social, cultural, psychological, technological, and economic means of convincing people, especially members of hard-to-recruit populations, that they want to become and remain human subjects. So a lot of my talk, the rest of my talk will be under the umbrella of recruitment science. So with that, let's think about gatekeepers. Gatekeeping is an activity of controlling and usually limiting general access to something, a function or system that controls access to something. So when we think about clinical trials, and we know we have inequities in clinical trials among men with prostate cancer, who are the gatekeepers? Well, there are a variety of gatekeepers, and we're going to think through that. One key gatekeeper that we recognize is myself, my colleagues, providers. 77% of patients that enroll in a clinical trial do so because their provider recommended it. And while we have a variety of stakeholders involved in our clinical care and involved in offering us a clinical trial, the government, industry, research organizations, the insurance companies, the investigators, the researchers themselves, the healthcare systems. At the end of the day, the provider needs to recommend this. The provider is a bottleneck. These are also different gates. The provider is a key bottleneck, and only about 13% of oncologists in the United States regularly engage in clinical research. We know that this bottleneck is a big driver of inequities in whom clinical trials are serving today. And here we highlight racial ethnic inequities. We also know that there are gender-based inequities in other tumor types. But at the same time, it leads to inefficiency. And so studies are taking quite some time to enroll, and it takes longer for us to access therapeutics that may be beneficial to us. So the recruitment science literature is vast, but I'm going to be pouring into patient and societal factors a little more deeply, thinking about socioeconomic status and insurance, belief and attitudes about clinical research, historical context. I'm going to think more about provider factors. I already mentioned that providers are a key gatekeeper in access in clinical trials. We'll talk about institutional factors, including clinic resources, translation resources, research support, and trial design. The role of DEI prioritization, thinking about eligibility criteria, trial site selection, study materials. The net result of all of these different factors and components is what we have seen, which is unequal access to clinical trials. And this is why we need to think deeply about this in order to advance equity in whom clinical trials serve. So patient and societal factors. We know that there are out-of-pocket costs associated with clinical trial participation, such as travel and lodging. And at Dana-Farber, at MGH, there was a program that was established called the Cancer Care Equity Program. And this program provided financial support to address the out-of-pocket costs associated with clinical trial participation among eligible patients. Patients were eligible if their household income, combined household income, was less than 700% of the HHS federal poverty limit. What you see here is that after the initiation of the Cancer Care Equity Program and the offering of this financial support, there was an acceleration of enrollment to clinical trials at the site. And among recipients of these of this program, of the financial support from this program, you see that they're enriched for being much more likely to be bothered about financial concerns, concerned about travel costs for the trial, concerned about lodging costs, worried about affording their medical costs, afraid about health insurance being inadequate, being worried about being able to adhere to a trial schedule, and worried about transportation to trial center. So it goes to show that these pragmatic concerns were top of mind for patients. My research team and collaborators also implemented a financial reimbursement program at 2 sites, UCSF and USC, which address the out-of-pocket costs associated with travel and lodging. And what you see here is the breakdown of the costs that were supported. You can see that a good chunk was associated with lodging support to attend clinical trial visits. Patients also had a variety of other ground transportation needs, such as gas, parking, and others. And there was a subset that had air transportation needs, such as flights. What you can see here from looking at the frequency of reimbursements by the different sites is that there was regional variation between the types of travel support needs that were required. And that what you can imagine is that patients traveling to Southern California may have different needs than patients traveling around the Bay Area, just given the distinct topographies of the 2 sites. Now, when we think about provider factors, I already mentioned a really key learning, which is providers are gatekeepers in clinical trials. But providers have biases. Ethnographers Daniel Dohan and Galen Joseph observed patients at academic medical centers and providers at academic medical centers and started to understand the different attributes that providers were looking for implicitly in order to offer a clinical trial to a patient. They were asking questions like, is this patient proactive? Is this patient meticulous? Do they perceive good communication? Is the patient adherent, embedded in a social network? These are attributes that would lead to a higher likelihood of being offered a clinical trial. And when you step back and think about this, you can see why that might be the case, because the providers are trying to finish their clinical trial. They're trying to get patients that will stay on study. They're trying to have patients that will be perhaps perceived to be easier to manage. These are all biases that are driving systematic exclusion of certain populations in clinical research. We also see that the provider within a health system is coming in with their own beliefs, clinical factors, social behavior, social status, and other perceptions that will influence the way that a provider interprets and synthesizes the information that is delivered to them from a health seeker. So the health seeker's race, ethnicity is digested and processed by the provider based on their own set of biases and lived experience. And that leads to influence of their professional decision-making and the services or treatments being received. And this is really key to just acknowledge, and why initiatives like the Just Ask initiative that was started at Duke can help with some of the barriers in whom clinical trials are serving today. Now, institutional factors are also important to acknowledge. There are structural contributors to cancer clinical trial inequities. It could be related to organizational and climate and clinic resources. For example, are the providers stretched too thin to even discuss clinical trials? Recruitment does tie up clinic exam rooms, and perhaps there's a high volume of patients that need to be serviced. Maybe the clinic is difficult to navigate for the average patient, and that leads to reticence among patients to engage in activities that might require more visits. Perhaps there are long wait times to be seen, which is much more disruptive for a patient's life and leads to further reticence to engage. There may be limitations around research-specific resources. Perhaps multilingual support needs aren't being met, with limited translation resources available and materials not being translated in multiple languages. Perhaps trial information dissemination is limited. Maybe most providers within a clinic don't actually even know what trials are going on and have to be reminded, and there aren't simple tools to help them keep up. Navigators may also not be available. Navigators both to offload the providers from doing any heavy lifting associated with implementing a study, but also to help walk the patient through the trial journey and to make it more intuitive. These are all resources which you can imagine vary across different clinical environments and can be a big predictor, if available, can help drive recruitment to clinical trials in a more equitable fashion. Now, research design and analysis is also relevant. I'm going to go through this really quickly, but it is really important to think about intentional design and making sure researchers are thinking about this even at the clinical trial concept phase. Thinking about the epidemiology of the disease that is going to be included or reflected in the clinical trial, making sure that there's a model to achieve targets around certain representative recruitment goals. Thinking about the research team and the diversity of the research team, thinking hard about eligibility criteria and if certain criteria can lead to systematic exclusion of certain populations, thinking about the role of study procedures and whether any seem like a heavy lift for patients that could lead to patients stepping away from the opportunity, and also reflecting on pragmatic things like study sites and materials and what barriers they can either remove or create. Data analysis, even in the preclinical phase, is relevant. We acknowledge that race is a social construct and not a biological variable. We also recognize that there is genetic variation in ancestry, that genetic variation and ancestry are distinct from race. The role of race in data analysis is to serve as a proxy for social and structural determinants of health. And we know that if we can have diverse patients on trials, we can make more generalizable conclusions. We can generalize the conclusions of the clinical research. We can also identify, based on the data that we use, whether or not we do not have sufficient subset of patients to make valid conclusions about safety and efficacy for all. So given that, I wanted to shift gears and to really round out this conversation with pragmatic approaches to health equity. And there are several pragmatic opportunities to apply an inclusive research approach. And these are things that investigators, providers, and patients can be thinking about. So the infrastructure. Within the clinic, is there a promotion of workforce diversity? Is DEI and cultural humility training part of the requirements for that environment? And is there a focus on making sure that there is readability of consent materials and it's available in gender neutral language and is multilingual? From a clinical trial design perspective, prioritizing DEI in all protocols and concepts is important. Defining diversity research priorities as it relates to various identities and patient clinical factors and being intentional around this is also key. And evaluating eligibility criteria very closely, as some can lead to systematic exclusion in certain populations. One example of this is thinking about things like comorbidities. Comorbidities meaning if a patient has multiple types of health conditions. As you can imagine, a patient that has less access to health care will have more comorbidities that are uncontrolled than patients that have a patient that has less active access to healthcare will have more comorbidities than a patient that has more access to healthcare, and there may be as a result of that, that patient is also going to have less opportunities to engage in clinical trials if they require optimized comorbidities. And so it goes to show eligibility criteria must be scrutinized to think about its cascade impact on diversity and inclusion in clinical trials. Now, trial site selection is also very important. It's important for investigators to evaluate the demographics of patients serviced at study sites, consider incentive models for sites recruiting diverse patient populations. And then lastly, community partnership and engagement. This is so important. Engaging local providers, having an ear on the ground on community needs and being attentive, and then early partnership with patients and advocacy organizations. Now, I bring all this up because I think it's really important that the onus is on the gatekeepers and on the research ecosystems to create a more equitable and inclusive environment for clinical research. I do think it's also important for patients to be empowered with the tools, information, and resources that they need in order to identify clinical trials that may be well suited for them. But I don't think it's the patient's job to do all that homework. It's really up to the system and the providers to transform it such that it is more intuitive and accessible so that patients can be afforded a chance to consider opportunities that may be well suited for them. With that in mind, navigation is a really important piece to health equity. Patient navigation integrated with approaches that address social determinants of health. Social determinants of health are the conditions in which a person lives that influences their health outcomes. We know that navigation plus that type of support can increase clinical trial recruitment, has a larger effect on larger late phase clinical trials. And this model is also primarily in service of more diverse patient populations. Navigation helps and is a huge mechanism for accelerating equity in whom clinical trials serve. The other key piece is genomic testing. We know in clinical trials today, especially in the advanced disease setting, genetic information is very commonly used as part of eligibility information, but yet genomic testing and genetic counseling is not equitably accessed. So this leads to this cascade impact of inequities in clinical trials by virtue of having inequities in whom is receiving genetic testing. There are a variety of resources that can help clinicians, especially in under-resourced settings, counsel patients, and there are a variety of resources for patients that are educational about the role of testing, what the process looks like, how to find a genetic counselor, and to understand the impact of the results. These types of resources can open up access to genetic testing, which by extension can help open up access to clinical trials. Now, I wanted to share this from a piece by Dr. Doyen and Joseph, published in the Recruitment Practices and Politics of Inclusion in Cancer Clinical Trials. What they wrote is that given the heterogeneity of clinical trials, research infrastructures in the U.S. healthcare system, the meanings of inclusion in research are multiple, and inclusion by itself does not ensure equity. And it really shares that there's just so much more work to do. So I wanted to close here with these visuals, which is that when we think about equity in clinical trials, we need to understand the differences between these terms. Inequality means unequal access to opportunities. And what you can see here are two beings with unequal access to the opportunity of an apple due to this structural difference that leads to circumstances of advantage for some and disadvantage for others. Equality is about evenly distributed tools and assistance. So here you see that there are evenly distributed tools and assistance, but yet there is still a circumstance of advantage for some and disadvantage for some. Now, when we go to equity, there's the role of custom tools that identify and address inequality. So that's a lot of what I sort of discussed in our conversation today, which are some strategies and tools to promote equity in clinical trials. These customized tools and interventions to promote circumstances of advantage for everyone. But what do we really want? We want to change the structures that lead to circumstances of disadvantage. We want justice, fixing the system to offer equal access to both tools and opportunities. And this is the goal. We have a whole lot of work to do to get here, but this is certainly the goal. We want justice and access to all resources that may be beneficial for the patients that we serve. So with that, I thank you for your attention and your time, and hope that you learned a lot through this conversation. Thank you.